This brings back memories of hot, sunny afternoons in a porter cabin at school, trying to remember geography lessons. It's got that sort of feel to it. Hopefully, there's some ventilation there. If anyone feels slightly heated, there's water available outside. Please feel free to avail yourselves of that. It's really nice to see people here today, particularly as what we want to do is this meeting is about stitching together the various services that we provide so that we can work effectively, collaboratively, and we know what each other are doing. So as we go through the agenda today and as we move later into the development session, that's really what we want to have at the back of our minds in terms of where we're going. So we've had some apologies.
Yes, we do. We have apologies from Jan Breton, Anna-Reese Gates, Nick Johnson, and Stuart Dipple.
That's cool. And to build on that, it would probably be useful if we did the thing. We're not going to do role play today, I promise you that. But if we did do the other traditional thing of go around the table and just introduce ourselves so that we all have a refresher of who we are. I'm Steve Robertson. I'm something to do with adult social care for Dorset Council.
Hi, I'm Jonathan Price. I'm the Executive Director for Adults, Health and Housing, Dorset Council.
I'm Patricia Miller. I'm the Chief Executive of NHS Dorset Integrated Care Board.
I'm Andy Davis, Corporate Director for Education and Learning and Children's Services.
I'm Paul Dempsey, Corporate Director for Care and Protection, covering for Teresa Levy, who's on leave, and I take up a post as Director on the 3rd of October.
Hi everyone. I'm the Cabinet Member for Children's Services, Education and Skills.
Jill Taylor, I'm the Cabinet Member for Housing and Health.
Mark House, Area Manager for Shared Programs.
Hi, I'm Sarah Sewell, Head of Service for Commissioning for Older People and Home First.
And I'm Sam Crowe, Director of Public Health for Dorset Council and BCP Council.
Celia Bufton, Chair of the Integrated Care Partnership.
Hi, I'm Louise Lyon. I'm the Head of Service for the National Vulnerability on 17 and BIC.
I'm Steve Mercer, the Councillor for Blackmore Bay.
Errol Jones, representing Stonehenge to Newton.
Margaret Guy, Vice Chair of Health Watch Dorset.
And George Dyer, Democratic Services.
We're joined online by a number of people. It will not work if we all introduce ourselves individually. So can we note everybody who's on there? Otherwise, there will be 10 seconds between each person. So welcome everybody to the meeting. We're going to start off with the minutes of the last meeting. Everyone had a chance to read them? Yes.
Before you do that, would it be possible for George to contact Dorset County Hospital? Because I think it's a while since we've had a rep from there here. That doesn't sort of feel right when you've got such important conversations to be had about people.
Yeah, that's a very good point. If any member feels there's others that should be at the table, this is about a tapestry, about bringing things together, then please let us know.
It's just that we haven't had here for at least an opportunity.
That would be useful to check upon. So minutes of the last meeting, everyone has read them. Can we take them as a correct record first? And I have a proposer and a seconder. 2 councillors. And now any matters arising?
You mentioned that in terms of the Better Care Fund, there is scope for use vehicle in terms of work for the ICP strategy. There was going to be an informal meeting. I just wondered how that informal meeting is playing out, whether it's actually an informal meeting with the ICP, and I don't see it in the work.
Sam, do you want to respond?
Yeah, thank you, Chair. It's a good question. I think in the development session this afternoon, we're going to talk about refreshing the strategy. I think an equally important conversation is, as the place-based partnership gets going, how does that work plan start to draw on the ICP strategy and some of the other important things that we need to do to improve outcomes for residents. So hold that thought, and if you can stay for this afternoon, it'd be great to have that conversation then.
Right. Any other matters arising? Yeah. Oh, sorry.
On my second point was an item noted on page 9, where it is stated that the local enterprise partnership focuses more on BCP Council, Dorset Council. And I would challenge that that is not a correct statement. The local enterprise partnership is a partnership. It has the leaders and councillors from both local authorities on the board who direct our work and have historically done that. And we also have councillors who sit on our overview and scrutiny board who also scrutinise where monies are spent. But we do get those types of challenges that more money gets spent in one place than another. We have yet to find that evidence. I just remind us that you are part of the partnership that is the LEP. So again, if there are things that we should be doing. And in the context as it is there of social mobility, again, we have a great careers hub focused or led by Dorset LEP, but also with colleagues from both local authorities on board there who have done a lot on providing additional careers opportunities and careers fairs specifically for individuals or young people with SEND. So again, I challenge the premise of the statement that more money or more time or money goes to one place rather than the other. But I would also say that both councils work really closely with their chambers of commerce. They have to. It's part of what we should be doing. So that part of the statement is correct. But I'd like either that for it to be corrected or some information to be provided as to the basis on which that comment is made.
Is there any response that people would like to make, or then we're happy to correct?
Thank you very much. That's very good. Thank you.
I just wanted to add some information in relation to the article last time about the safeguarding families together gender item, which was about adult services professionals working with child protection, social workers. And there was sort of some questions, I think, I wasn't at the meeting, about needing to do some more work to fully evidence that in that to the model. We are rolling out wider from October. It's part of our Pathfinder programme. We've made previous commitments to the DFE as part of that transition strategy to roll it out as part of increasingly integrated multidisciplinary services. So we have done some recruitment of that and it's rolling out, but it would be a place to provide further evidence about how that initiative works, and I'll bring that back as we get it and we roll through the rest of the year.
Very welcome, thank you. So we're looking for a proposal for the minutes. We've had proposal and second, so they're now corrected. Okay. Any other items on the horizon for the minutes?
You can never go off because I'll forget all that. All the second or all that. We don't do any of that, you know.
I envy you.
I need some teaching when I cover for you, otherwise it comes.
I've got you. What you need is a George. George is very good at keeping me alive. Do we have any declarations of interest for the meeting today? We have none, then we shall proceed. Public participation. There. Normally we have any questions that have come from the general public. I do not believe there are any questions today. And then we have any questions from councillors. None have been received.
No.
But to make things as open as possible, are there any questions that councillors may wish to ask at this point? Then I shall take that as opportunity to move forwards. It is a hot afternoon after all. Okay, so as we move into the agenda proper, for me, this is really quite an exciting meeting, as much as it can be stuck in a porta cabin doing geography on a sunny afternoon. Because what I've asked for following our last meeting is that we have the opportunity to go a little more in depth into some of the things that are being discussed. As a newbie, a lot of the phraseology that is used is actually quite new to me. And I'm also forgetting a good 60% of everything that everyone is going to say, well, we did tell you. So it's an opportunity just to refresh and give greater foundation to some of the things that we're doing. And it's also a reminder for those people that are joining us, particularly online, of some of the really good work that is going on through the Better Care Fund and through the work of this committee. So our first thing is to look at the Better Care Fund. Who takes the lead on this?
Sarah's going to lead this.
Sarah, do you want to take a lead on that?
Oh yeah, sorry. Failed at the first hurdle. There we go. Right, ready. you have in your reports pack, so you've got a report and then the template, which is an Excel template, the usual kind of format that you receive at the board. So just by way of introduction, at the last meeting when we brought a previous return, the board was quite keen that we take a slightly different approach to future conversations about the Better Care Fund, and trying to kind of move to the board members have more sort of contributions to the reports before they're submitted. It does get a bit tricky because we have this real sort of set rhythm of reporting, and we're not always sort of clear on the dates and papers are going to be due to be submitted back to NHSE. But what we've done last time in response to that conversation was that we shared with board members the document that we had to submit in advance, so that we had an opportunity for feedback. And actually what we've done this time is within the paper, I've just gone into a bit more detail as to actually what we're looking at. And it's good timing this time round because it's just focused on one part of the Better Care Fund. So rather than delve into all of that detail, it's kind of just a bit of a snapshot that's quite succinct around discharge, mainly discharge from hospital activity. So just to kind of start perhaps a bit of a different kind of look at BCF, which could help us get into a bit more detail about how the board might like to receive future information, how we might look to start to change how we're kind of working through with Better Care Fund. Also kind of, so part of the conversation today is to get your feedback on the information that I've provided, but also just to flag we are getting to that point in the planning cycle where we'll have new plans that we'll need to put together. We've got, I'm excited about, there's a new appointment, a new colleague in the ICB. Judith, that's joined the team, has got some experience in doing Better Care Fund in other places, so really good opportunity for us to start to look together as partners about how we kind of move this forward, because it is that joint kind of approach. So that's kind of just a bit of an introduction as to where we've kind of got to. The recommendations for the report today are around, again, retrospectively approving the template, but then just, as I say, getting a bit of feedback from you, please, on the content and how we've kind of outlined the information today. So I don't know how much detail you want to go into. I've kind of talked through the kind of the key sections, if that's helpful, or we could just have, work it on that basis. Okay. So you'll see on the template, the discharge funding is sort of broken down into the lines, and within the report, so if I take you to section 3 of the report, we start on our home care market investment that we've made. And as I say, I've kind of outlined the report in terms of what the challenge was that we're trying to address, the impact that we've had to date, and how we could focus on our plans and intentions going forward. So in terms of that home care capacity, we had about £2.5 million worth of funding in the discharge funding that we've invested into that home care market space. And that was to address the issue that we had, which as a board, you've heard us kind of talk about it before, in terms of a few years ago, we were really struggling for that home care capacity. It was meaning that we were having to discharge people to places that were less than ideal, so needing to use more care home placements than home care. So we looked to embark on a programme of home care optimisation, so working with our provider market to make more efficient deployment of the resources that we did have available to us. And we did some work around our contracting methods so that we had more localised zones, so we made better use of at the time the caring time that was available rather than wasting time travelling. We also attached to that, we were early adopters of the fair cost of care approach. And through that, we managed to get more transparency over our home care rates. And really importantly, we were able to help drive forward better pay for care staff, because we could see and we could drive the costs that actually we knew the providers could afford to pay a certain amount to care staff. And that's had real good impact. In Dorset, we've seen a real turnaround in the market. And we're seeing a reduced rate of admission to long-term residential homes as an alternative to care, and about 89% of our long-term home care packages are now placed at our framework rates with Dorset Care framework providers. And we've really seen as well that reduction in waiting time for care. So we have more or less no waiting time for searching for care, and very little placements that we haven't made any recent placements off framework. It's all with our framework providers. So in terms of longer term sort of focus, we need to really focus on maintaining that stable home care market, making sure we've got that good quality provision in the market, and working with providers so they're ready to help us manage this higher acuity that we are seeing in Dorset residents that we're supporting. So continuing to work through that, looking at how we kind of link in with that sort of partnership approach, neighbourhoods. So we've got sort of greater zonal optimisation and place-based provision. That's kind of the next step in terms of our commissioning plan and how we kind of continue on that vein. So that's the kind of the first line of the plan. I don't know if I pause for questions.
Thanks, Sarah.
Yeah.
Just a simple question from me. If we have reduced the delays in obtaining home care, has that had any impact at all on speed of discharge?
Yes. So we've it's massively helped with hospital flow. And we've been doing a lot of work with our, so later on in the report, the next item actually on the report is our recovery and community resilience contracts. So that's our enhanced home care out of hospital. So what we're seeing is we're able to improve flow through those schemes because we've got the care in the community ready for when people need it, when they've sort of finished their kind of intervention.
Thank you. Cecilia?
Can I just ask, how do you notify the market, as you call it, the companies on your framework of what the future pipeline is likely to look like for their planning purpose?
So we have forums that we hold with providers, and we've also got a really strong relationship with our Dorset Care Association. So they help us manage our engagement. We go into regular sessions that they would be having to kind of give the market the heads up as to what we see coming, what challenges they're experiencing. So we're kind of really developing that partnership approach.
Thank you for this narrative report because it's a lot easier to understand. I think there's something about, and it might be when we get on to the next stage of what it might look like in being clear about the problem that we're trying to solve, but also being clear about the starting point in terms of the baseline and what it is we're hoping the investment will achieve going forward. Mm-hmm. And given that some of us have already seen the high level findings from Newton, if we choose to go ahead with that work, there's obviously things within that need to then filter down through what we do with the Better Care Fund investment going forward, and particularly thinking about whether we want to direct some of it towards prevention further upstream. But just tying the narrative together with some real numbers will help, and the spend will help the board understand whether Better Care Fund is really making a difference in the places we want to, with some facts and assurance around it that gives that confidence.
I'd agree with that. In fact, would suggest that, Cecilia, if you're okay, that we do a presentation to an ICP at some future point, so we can actually give some real feel good to the people who sit around the table in some of the practicalities that are going on. So, do you want to carry on?
Yes.
Oh, sorry.
Yeah, I mean, just to add, I suppose, we don't do anything on our own. We do it with our providers, so the businesses that are on our framework and our partners. And I think, we have made a difference in that space. It is a better partnership. Part of that is sharing information. So there's a lot of data that we do share as well, anonymised data, but that helps with predicting what demand's going to be there in the future. And to a degree, the complexity of demand, which is our other challenge. So I think good progress, but we've got to keep going and use the evidence-based approach that we've got underpinning this to make some of those decisions.
Yeah, I'd agree. Oh, sorry.
I'm just wondering at what point...
And it might come.
Sorry, I'm just wondering at what point you reach out to the voluntary and community sector for doing some work within their local communities that they can handle with that ease the capacity you might or might not have within the care sector.
We've got the BCSE. We'll get there in the end. But
let's just all turn them on.
So BCSE is a clear link. So we've got sort of dedicated teams that are working in those hospital discharge pathways, and we've kind of been developing our contracts so that we can link out. And we've actually done some dedicated forums that I mentioned. We've done some dedicated sessions inviting the BCSE representatives in to sort of explain to home care providers, as an example, what services they've got available, and you could really see the light bulbs sort of going off. And they were kind of thinking of specific examples of that could have helped so and so, and really kind of spotting the link. So we can always do more in that space, but we have got those sort of links we're building in on a more regular basis.
Right. So who would a local charity contact, for example, to understand what's needed further?
They can contact the commissioning team directly. I can go through the contact details for that, and we can explain what contracts and how they would link together.
Yeah, that's great. Lovely.
There is definitely the opportunity to reskill and upskill, whatever the correct word is, the voluntary sector and other providers as well, to once we identify the specific needs that are being looked for. I think there's a huge opportunity to bring communities together. It's not even necessarily voluntary groups, but individual neighbourhoods and community is an opportunity. Oh, someone online?
Good afternoon. Permission to speak. It was just to say John Sloper did some targeted work within Dorset, I think it was Poole or Dorset County, I can't remember, on supporting discharges. So there is quite a lot out there already, Carol. So it would be good linking with him. And he is the conduit to local services in local areas through the project that he ran. So that had some very good outcomes, I believe.
I'm looking forward to the opportunity for this group particularly to stitch together GP services, voluntary sectors and others, so that everyone's working together, and how we can establish a skill base but also a trust base for how groups can work together to benefit clients. Moving on.
Okay, so the next section is around our recovery and community resilience contracts, which we've just touched on as the example of kind of improving hospital flow. So the situation that we were in was that we're kind of trying to get people. We kind of know that the best place for a person to recover is at home, but that lack of home care capacity was sort of stopping that from happening in as many cases as we wanted it to. So we developed this contract that we call Recovery and Community Resilience, which is that short-term enhanced support to help people home. So we've kind of working with health partners, we've invested some of this discharge funding into those contracts, and actually the results have been really impressive. We're seeing much higher numbers of people being supported back home because of the RCR contracts. Just to give you kind of a sense of scale, on average there's about 160 people who are being supported at any one time, particularly at Dorset County Hospital, where we would kind of support the most people coming out of hospital because of our kind of geography. About 50% of the pathway 1 discharges go through RCR, so having that sort of significant impact. And about 30% of people that are going through that service don't need any care when at the end of their recovery period, and about 35% of people who do need care, in the main, their care packages are reduced when they finish that service. So really kind of helping with independence and maintaining the kind of position from prior to hospital. So really good outcomes we're seeing through that service. And kind of to Patricia's point around sort of where we go next with our sort of system improvement work, there's real opportunity in that model as to how we kind of look to develop those sorts of models in that pathway 1 going forward. So that would kind of be an area of focus for us to consider longer term about how we need the home care market to really support us with that meeting higher acuity, helping us hospital discharge pathways. So that's kind of a real good example of how we could link that sort of future focused, more system wide work across with the kind of adult social care market for harvesting sort of opportunity. So that's the next line of the fund, if there's any questions on that part.
Jill?
Yeah, just a couple of questions. So people coming out of hospital, we're looking at sorting them out with domiciliary care and that sort of care, also the reablement. How are we with capacity for, say, nursing care that's required at home? I'm just thinking if somebody comes out and they need a district nurse coming in all the time, have we got capacity within their section to be able to do it? And also with, say, a patient who needs to come back into hospital for regular treatment, are we okay further on down the line? That's my first question. I have got a second question.
Yeah, so community healthcare, Mike.
Yeah. So maybe I'll lead off. So there are gaps in that space in our specialist skills that we don't know. So I think there's more work to do in that space, but the actual kind of ability to get someone home in the first place with care and sitting services we've got, but the enhanced model of care is really the area that we need to work to improve. And actually, you'll hear later around the work for UEC and how that's pulling out perhaps some of these strands of work that we need to work much more closely together with health colleagues to expand.
Okay, thank you. And if I can just comment on there's a line in 4.3 about the NHS withdrawing some of their investments. I find this really sad. And if I can echo what Patricia said earlier, that we haven't got the NHS here. So we haven't got the voice for them to comment. So I'd just like it noted about how much we really would value their input into these meetings. Thank you.
I think that's important because it's not just about having healthcare. So we've got to get them here. We need to understand why, because we need people around the table. I can't speak for them as a commissioner.
Thank you. Good point.
Move on to section 5 for trusted assessors. So the challenge that we were seeking to address through investing in trusted assessment was around sort of delayed discharges from hospital and improving relationships between our adult social care providers and our health and social care colleagues. The care homes require an up-to-date assessment of a provider's care and support needs in order to ensure they can support them safely on admission. And prior to 22, that was adding several days to a person's stay in hospital whilst we waited for a provider to go in to assess, update their information, then make a decision about whether or not they can support the person. So working with a representative from the market and the Care Association, with colleagues from Dorset County Hospital and DC representatives as well, we developed a pathway of independent assessment through hosting through the Dorset Care Association. So what we do there is that there's a trusted assessor that's on site at Dorset County Hospital, and they go in and see a patient that's ready to leave, and they conduct that assessment on behalf of the provider to really cut down on the amount of time that it's taking, so really reducing the delays in people waiting to leave. And they also then sort of keep track of that person's journey ready to be discharged, making sure all of the coordination elements around equipment, meds, transport are all ready at the right time, so the person can leave the hospital as soon as they're ready. And has been a really successful programme that is now part of our kind of core Home First offer, part of Discharge to Assess. And there's an awful lot of interest actually nationally in the model that we've developed. We've just done a BCF learning lunch presentation, myself and Anna Knight from the association. So there's a lot of interest in kind of the benefits that we've seen through that. And as I've outlined at 5.2, so each month there's around about 65 people that are being supported back to their normal place of residence. And we've got over 130 providers that are signed up to accept those trusted as well. So really seeing that kind of improvement of relationships as well. And where we have, as an example, if we have sort of particularly complex cases and needs that need to be supported, again, we've got that independent view to help us work through as a collective of health and social care professionals about what's the right steps and the next steps for that person. And there's also outlined in the report just sort of a high level outline about the offer that's supporting some of those prevention elements as well. So the trusted assessors will support from the emergency departments as well. And there's some particularly powerful case studies around support for people with more complex sort of learning disability, mental health related conditions, where the environmental element is so key to how they present, and the trusted assessors being able to support in those situations and get the person back home has been really powerful. So that's an area of funding that we would just like to expand if funding across the system allows. But we've got commitment to continue the service as it is. There's opportunities to expand if we can.
Questions, comments?
Are we using sort of telemonitoring, remote monitoring, digital technology to keep people safe at home yet? Is that something we are continuing to expand?
Yeah.
Okay.
Yeah, I think there's always room to do more, but we have offers around sort of care lines, different types of digital responses to help with those monitoring. We particularly pilot different sort of solutions that help sort of monitor people to see what actually is their baseline when they get back home, because so often people are much better than is expected when they get home. So just managing that risk on those sort of early days of discharge, really effective.
And so do we understand how effective it is? What impact, what difference it makes when you have it and when you don't have
we will have some. I haven't got that that data to hand, but yeah, we can provide that. I think there is a lot more to do in that digital space. I think managing expectation and it becoming sort of the new norm. I think there's a key opportunity there in future kind of approaches.
Thank you.
Fantastic, thank you. I'm delighted. Thank you so much for that. Please pass on from everybody appreciation to colleagues and everybody who's working on this. Isn't it just amazing how a simple line on the BCF form has got so much depth to it and so much good work going on? I just think it's really nice to see. So often these meetings can be just a presentation of statistics, but actually you actually bring out some of the humanity, the reality of what we're trying to do. Carol?
Can I just ask a general question? I'm sorry if I sound a bit stupid here, but are there people that could come out of hospital that could be looked after by their family if somebody in that family was being paid more to do so, rather than spend what we're spending currently for reablement? I don't know if that's something that we could actually investigate.
That's a good question.
Something to investigate in terms of what are the barriers. That you understand. Yeah.
I mean, do you know approximately how much it costs for reablement for a person during a week leaving hospital? Have you got any idea what that cost is?
So we can quickly do an average package size against an hourly rate to kind of work that through.
Because I really asking that question. Sorry,
why are we asking that question? Because I'm just thinking that people go away and do a lot of work and then we don't know what the so what is.
Because if we are looking at giving people better outcomes leaving hospital, and we know their outcome will be better being at home, sometimes perhaps capacity isn't there, or perhaps they might have to go into a residential care facility for a short while. If they could be looked after by family, very often a barrier for a family member would be because they can't afford to stop working for a few weeks. But if they were being paid a better rate that could actually save us money from what we would be paying on reablement, is that something we should or could consider?
I understand that, but I think before we go away and do that analysis, we need to understand what the legal framework says for whether we're able to do that or not. Otherwise, we could go away and do a lot of work and then find that it's not something we can do in the legal framework that we're working within. Because I have never.
Is that because we would be paying the person?
Yeah.
Right.
Yeah. And we'll get into all sorts of issues about conflict of interest. So I think there's something about us investigating that first before we go away and do that.
Okay. No, fair point. Fair point.
It might be a bigger discussion because the role of an unpaid carer then is upended slightly.
Yeah. They've got some really good analysis at government level now that talks about if you were paying carers, you know, what in the billions do they contribute? And it's not that dissimilar to the total NHS budget, to be honest. But whether that then leads into a different conversation about how you financially support carers is a completely different conversation. And whilst there's a really strong push from the Lib Dems for that to happen, the reality is they're not in government. So I think there's something about checking the legal framework first before we run away and do a lot of work and then find that we can't do.
There may, however, be opportunities to equip unpaid carers better and to provide support, because it is a phenomenally draining role, as we know. Yeah. There may be ways that we can do that would be more easily achievable than taking government on head first. Okay, thank you. Good question. Sam?
Yeah, just in terms of next steps, I agree. I think it's focusing on the discharge bit. So I've come away with an assurance that we're getting better at releasing the flow. Be good to kind of follow this up with what's happening to keep people out in the first place. That's the absolute key, isn't it? So no matter how good we get at discharging people, we've also got to turn the taps up at some point. So if we keep the focus up in that narrative style, I found it really, really helpful. So yeah, thanks to the team that have worked on this itself.
Can I just follow on?
You will.
If I just follow on that, because I think one of the things that we're going to talk about in more detail in the next few weeks, about what Newton have found also, is how many people are going into residential care that shouldn't be because we're not getting to them quickly enough in hospital. So I think there's something around, as you understand more detail that sits underneath the Better Care Fund around what it is achieving, there's also something about us having a rounded conversation around which of the people we're not getting too fast enough, because obviously in health we talk about risk and risk mitigation all the time. We don't talk about it enough in the round as a system. And I think there is something about the Health and Wellbeing Board understanding which people are we not getting too fast enough in hospital, so we're in a place of decompensation and then into long-term nursing or residential care that could have been avoided, and how much does that cost, as well as the impact on the person, but also how many people have we got sat at home that are either on a suboptimal package or they're not receiving a package of care at all because they're on a waiting list, and what's the impact on them in terms of quality, safety, quality of life? Because until we understand that, we're not talking about the entirety of the picture that we need to fix.
Yeah, I agree. Now, do you want to say anything about reablement beds?
Yes, so just this is the final sort of line of investment on the report. So just to kind of, you'll have heard us talk about reablement beds previously, some of the investment at Dorset. So as we kind of described, it was sort of an additional approach to addressing sort of the shortfalls in reablement capacity. So through our local authority trading company, we did a rapid stand-up of about 30 beds in 2022-23. And that's since seen some good outcomes in terms of being able to help us maintain that flow. So average bed occupancy is around 80%, and length of stay is around 27 days. We're looking at how we can kind of further continue to improve that. And we can see from the data that longer term we are sort of reducing the need for care as people are discharged from those beds, and generally there's a bit of a flow where a person is wanting to sort of step down through the path that they go into a bed and then they're supported back home through reablement package. So it's not just a discharge straight home, it's sort of step down home as well to help that maintenance. I think this is a kind of another area kind of linking into sort of what we do, how we develop as a partnership in the future. So looking at what we can do longer term with those reablement, with that reablement capacity, how we kind of get best use out of the therapy support, kind of link some of the capital programme of investment that we've got around our reablement. There's sort of a clear link through that to our kind of longer term programme with Care Dorset, and how we kind of need to look at those workforce elements around sort of what we're looking at the moment around sort of future development of the allied health professional workshop, and how we can do some really exciting things with that workforce development and looking at sort of training and bringing new staff through to sort of meet demand as we grow. But John might want to kind of add a little bit on that front.
Yeah, so I mean, we will be taking a paper through council to have on the development of these centres, but I think it's fair to say some amazing partnership work that's taking place. Dorset County Hospital, potentially a site there, but also with colleagues in the academic space, and potentially, something that we might be able to link up as a sort of teaching site in the future. So, addressing potentially some of those shortfalls that Jill asked about in the workforce that we know exist. If we can develop people through the reablement centres, offer work, offer accommodation, key worker accommodation on the site as well, maybe we're creating the workforce of the future, in this area. So there's a lot more to come through the cabinet paper, but this was the prototype. So very exciting.
It is a time of change. Thank you. To move forward, Lou, you're online, I believe.
Yes, I am. Thanks, Steve.
Just one moment. Oh, yes, sorry. We need to retrospectively approve the Better Care Fund Quarter 1, 24-25 discharge fund template. This is retrospectively approved, but you did all receive, everyone received copies beforehand and had a comment, which is a big step towards the things that were mentioned last time. Oh, I've gone off.
It was me, Steve.
Oh, sorry. However, everybody in the room is what I said. We're asked to retrospectively approve the Better Care Fund Quarter 1 discharge fund template. Can I have a proposer, please? And seconder? Sam. Anyone against? It's carried unanimously. Thank you very much indeed. Have I done that bit, George? Thank you. Lou, sorry for that. I can't help being rubbish. Please carry on. One that we've mentioned briefly, the current research that's been going on, a report called Newton. It's not called Newton, the group is called Newton. They're doing some overall strategic assessment of our use of services. And Lou, you're going to give us an update on where we're at. You've got a paper in front of you, but it is quite loose at the moment. Lou, you're going to give us some more details.
Yeah, thank you, Steve. So, good afternoon, everyone. So, bringing a quick update and background to the work that the integrated care system as a whole has commissioned around a review of the urgent and emergency care pathway across Dorset. So we recognise that there are challenges in this space in terms of performance, how we support people to return home following stays from hospital, how we prevent them being in hospital in the first place, and how we how we reduce their length of stay. So in July 2024, there were 18.6% of people who were in a hospital bed had no criteria to reside. Now that compares with a national average of 13%. So as a system, we've had extensive conversations around a diagnostic piece of work, which we've commissioned an external strategic improvement partner to undertake on our behalf to do some deep dive work, some analysis, some shadowing, and a lot of engagement with leadership and operational teams to understand where the challenges are for the system. So Section 2 of the report just outlines a little bit more about the diagnostic exercise itself in terms of the timescale. We set quite a challenging timescale for the diagnostic, a 6 to 8 week period. Usually this is carried out over about 12 to 14 weeks. So we put a lot of pressure on Newton as our strategic partner to deliver in that time. But great engagement from our partners across the system at all levels, operational, BI, IG, and leaders to really get this moving at a difficult time of year given sort of summer holidays. So we've moved through that diagnostic phase now, and we're at the stage now where we're about to present the findings back to the system executive group next week, and later on this afternoon to the urgent and emergency care delivery group. So we've got some high level findings, which, as I said, we will share. But the next steps in this programme will be for those groups to approve movement to the next step through a gateway process for commissioning a strategic improvement partner for a system-wide transformation / change programme, which will commence later in this year. John, I don't know if there's anything else that you want to add.
No, I think probably just to say, a massive thank you to everyone who's worked over the summer to produce this. 6 weeks over the summer period is a really difficult time, and each partner across the whole system has contributed and brought goodwill and commitment, and I think we've just got to recognise that it is probably the hardest thing to fix in our system at the moment, and we're giving it a good go, but doing it really well in partnership. And then Patricia wanted to. Yes, on there, aren't you?
Yeah, that's your boss that who gave you that.
Oh, no.
Didn't tell him thanks a lot. So I think this work is really important because it's about making sure that when people come through urgent emergency care services, treated by the right person or supported by the right person at the right time, it gets the best outcome for them. That's not the service we've got at the minute. That's not to say that people are not working really hard, but we're not working in the optimum way to make sure that happens. The business case, as John says, comes to our system executive group next week for us to know whether we are prepared as a system to employ Newton as a partner to do the transformation alongside us. for the next probably 18 months as a minimum. It doesn't stand in isolation. It is intimately connected to the work that we're doing on with all colleagues around this table and beyond on integrating our teams that are working at neighbourhood and getting them to go beyond health and care and support the whole principle of thriving communities that are self-directed. But it is connected to that work. And so we need to be really careful that we don't find ourselves in a position of duplication because we're not clear where those two pieces of work cross over and where they have distinct elements that sit around the outside. I actually think the bigger challenge for us as a system, which is much easier sometimes for you in local government than it is for health, is how do we really co-design the way forward with our communities and put them in the driving seat, because that means ceding power to our communities, which you are much better at than we are in health, and we will have to help our health colleagues give that power away where it rightly belongs. But also that if we're going to commit to this at the end of the month, we need to commit to it. We need to sign ourselves into a contract that is legally binding, because what we don't want either is people commit and then when it gets a bit too challenging, you want to walk away, because we will still have to pay the design partner no matter what happens if we sign them up. So we all have to be committed to lean into it so that we don't just get them to help us deliver the benefits, that we also then take those benefits as cash out of the system to reinvest in the things that we need to going forward. So it's going to be a really challenging conversation next week, and that's on holiday. Before you let them stand up. It's going to be hard, but it's actually got huge power to give communities a much better quality of life.
Sam?
Yeah, thank you. That's really well put, because that was one of my questions, was how this all fits together and the phasing of the different work. At the end, you mentioned benefits, and without wanting to pin anyone down, have you got thoughts about how we start to look at that through a place lens? Because at some point, it would be really good to connect health and wellbeing boards in with what are we saying in our strategy? Where do we see the potential for involving communities and putting some proper resource in to really power our communities?
Yeah, I've got some thoughts, as in when you break those benefits down, they can do that by two local authority boundaries because they are quite clear in where they sit in terms of organisations. I think the conversation that we have beyond that, which is how does that work at neighbourhood level, ushering in something that's beyond health and care? I have an idea. I've been on a research project on that, and I need to talk to you about it because I have a little event that I want you to go to, so you can start to think through actually what does that actually mean for the place of Dorset, and how do we strengthen the partnership to really make that work.
It should be said out. Newton have also previously done some work with Manchester and Gloucester and Leeds and other places. So they have not a formula, but they have a methodology that has worked elsewhere with proven results. So although this is a new step for us going forward, it is not completely untested and unproven, so that we can have some confidence that the things that they are indicating are achievable might materialise.
We need to be really brave because they will deliver. It's up to us to transact it through the system. And that's when we need to be brave and just get on with it because we know it's the right thing to do.
Might I ask a question about, because we're talking about the whole of Dorset and BCP, which have two health and wellbeing boards, the importance of the health and wellbeing boards working together, because although we are separate areas, we share similar resources. And I think that will be quite critical, because one of the things that from the high level briefing is that actually is communication is key. And it would be a shame if it fell through at our level, which sort of like would build in a weakness within the overall structures. George?
Just with my health scrutiny committee hat on, if this is something that could be a substantial change or variation to the way health services are organised, then it would need to be considered by the health scrutiny committees in Dorset, either the one here in Dorset or in BCP, or potentially both as a joint committee. But we can look at that outside the meeting.
Okay.
George, because I think there's my view, looking at it as it stands now, it probably isn't a significant change, but there might be some things that, well, there will be some things that fall out of it towards the end as propositions about the way forward, particularly in managing the urgent care piece that we as health commissioners will need to bring to scrutiny if we're constant.
And the implications for working in different locations and all the other things will have to go through the necessary committees. But we need to have an overall vision. And this is where we can get that, so that we actually have some direction. Otherwise, things will stream off as we go.
Yeah. What do you think we need to be careful of is making sure that as partners we're keeping local councillors up to speed on where some of those smaller shifts are. Because and our MPs, because you're the people that our residents are going to go to, and we need to make sure that you're briefed properly so that you can explain the changes easily.
The stage we're at is that it's still the final report has not been completed or received, not by me, not yet. When it is, then we will be able to, assuming it's agreed, we'll be able to then have briefings for each department, each area, and each locality. Because if it's going to work, it is going to touch every locality. At this stage, we're not quite at that position, and we're not doing it because we're not exactly sure what the outcome is going to be. So that's why we're holding off at this stage. Other thoughts and comments? Take that as moving on. So we're noting the report and commending, I assume, the progress that has been made so far, and we look forward to future updates and the potential for the future. The next item on the agenda is what I found was B2SA. When I went through my induction as a councillor, I had no idea what B2SA was, but it looked very exciting. So I looked into it a little more, and the more I found out, the more exciting it is. I was talking to some colleagues in other councils over the weekend and just casually mentioned this outstanding piece of work that we're doing. And they were all very envious and would like to talk to us about how they can copy what we're doing. I don't know everything, or indeed much at all, but I just want to talk to introduce this.
Yeah, just a very few words. I had exactly the same experience as you did. I'm talking about this at a conference in Coventry last week, sort of envy. Yeah, obviously extremely welcome in relation to the cliff edge scenario. We know how extremely important this is. The plans I've discussed in some detail with Louise seems to be very robust. What I'm really liking is the inter-directorate cooperation. And again, I have some concerns about whether there might be any wranglings further down the road in terms of the budget implications, depending on who does the Care Act assessments. But I've been really reassured that that's very much in hand. And obviously, we're really looking forward to the next stage, working with health. And a welcome to Cecilia as the chair of the delivery board, new delivery board team. Thank you. Look forward to meeting you properly. And over to Louise for the detail.
Okay. Thank you. So I'm really excited to be about the progress with the Sutton Advocate Service. I think it was presented last September with very much the proposal being agreed. And so today is really an opportunity to give you all an update on making that a reality. So you have seen the report that I prepared in advance, and I have also just done a short presentation. Yes, so I have done a short presentation as well. First couple of slides are really to summarise the report, and then just to share with you some of the kind of key features of the service and what we're working on. The proposal and birth to settled adulthood is something that obviously has been in development for over 2 years and has really been a partnership approach between Dorset Council Children and Adult Services, Dorset Parent Carer Council and the NHS Dorset as well. And the new service formed on the 30th of April 2024.
And at that time, just prior to that, in March 24, there was a local area inspection completed by Ofsted and CQC, which really confirmed and showed positively, children and young people typically have positive experiences and outcomes of local services in the area. But obviously the ambition was to do more and to make those experiences even better and to support our young people to achieve even better in their lives. And so the work was already underway to develop this service, but we have got an outcomes framework that we have co-produced with our children and young people and families. So we'll be focusing on that in terms of the ages and stages of our children and young people, kind of really sort of focus our assessments on what skills are we helping them to develop. Oh, George has just a question. I'll say, do we want to share the presentation? Sorry, you've got a copy of it. Are you able to share it with everybody? I'm not joined on the Teams. You can see that. Thank you. Just slide 2, please, George. Yeah, that's great. So that's just what I've talked through so far. We've got currently 932 children and young people being supported by the service at present. So that is a majority of children and young people that are within the birth to settled adulthood service. And we've got about 260 young adults that are held and supported within adult services that are not yet settled. And the concept of settled is one of interest and something that we've been working together to define. So being unsettled perhaps means that you're not yet in the right accommodation and perhaps don't necessarily have a final confirmed level of support that you need because you're still developing skills. You might be completing education opportunities and then hopefully having aspirations to go on to some work experience or work. And so because between the ages of 18 and 25, there is still quite a way to go in terms of that development. We call that unsettled, and we hope that within our support that we're going to achieve that those young people become settled. And so we have a proportion of our adult services teams resource that are working with us to support those young people.
Can I ask a question?
Yes.
What settled means? My microphone's on. Are we defining what settled means, or are our young people defining what settled means?
Well, we've tried to share the definition so that we can obviously agree that between and get feedback on. So we've come up with a definition. We've shared that amongst our partners. We will need to take it out to our children, young people through our groups, so that they.
A little challenge.
Of course, yes.
I think we do too much defining of and don't listen to what people actually need. And to me, that definition needs to sit with the individual, because what is settled for one person may
it's very different
for another.
Yeah.
So I just offer you that challenge.
Yes.
Even in public service in general, we're far too paternalistic with the public and telling them what we think they need and where they're at in their lives rather than listening to them.
Yeah.
So our interpretation of that may be very different than the individual, because it's not our view of whether they feel settled, it's theirs that matters.
Yeah, absolutely. And that's an important point to raise, really, in terms of we are anticipating that we will work with young people up to the age of 25. However, people will become settled at various different points in their lives when we've supported them to meet their outcomes. And so somebody could actually be settled quite early on at 18 if their needs remain sort of the same and they are very much settled in their accommodation, their support. And actually, if they've got much further sort of outcomes to achieve, then they may not achieve that until a bit later, and some of them could stay with us until 25. So I think that's really important to articulate that difference in terms of it being tailored to the individual young person. And obviously that means that young people will exit our service at various different points into adult services as well. So the number of young people that we're supporting at any one time could change. Hopefully we're doing a good job in making sure that, you know, they're getting those opportunities to continue education, they're being successful within voluntary work experience and employment, and they've got really good, meaningful activities, and they're part of their community as well. So that's what we're aiming for. Okay, slide 3, George, when you're ready. So in terms of the preparing for adulthood sort of model and how it's going to work, I thought it'd include a little bit more detail because Councillor Sutton asked some really interesting questions. So we have the preparing for adulthood team now that sits within Birth to Settled. Oh, sorry, I think I'm just one bit before that. That's it, yeah. We've got the Preparing for Adulthood team that sit within Birth to Settled Adulthood, and we obviously support the children that are in B2SA, but we will also have and do very close working with other teams within Children's Services. And we'll probably likely get referrals for other children in other services. So we're talking about the permanent service and the care leavers service as well. So they might not necessarily have been known to Birth to Settled Adulthood children, but they will need that coordination for assessment in adulthood. And then that's how we link in our adults teams. We may well also have referrals in when young move into the authority from other areas as well. We've got plans in progress to develop our Birth to Settled Adulthood coaching strategy, and this model will help us to be fully sighted on the needs of children and young people as they move through their childhood and move into adulthood. A really important feature of that is the accommodation strategy for 16 to 25s. And that's got they've got plans there to develop various types of accommodation and support services. So we're very much linking into that. The information that we gain about our young people from 14 upwards will help to shape what's developed in the future. We've got plans to develop our short breaks offer, and there's more information about that later on. And a really important milestone, I think, within adult services is the preparation for the CQC assessment for adult social care. That's the first assessment that's due to take place at some point in 2025. So we're really working together to make sure that we've got really good information in preparation for that as well. Okay, slide 4. Lovely. Okay, so we've now got, so Birth to Settled Adulthood. Prior, the structure was that I think there was a children with disabilities team, one in the east and one in the west. We now have 4 locality teams, one short breaks team and an occupational therapy team for children. And our teams have been aligned to the locality teams that have been implemented through Pathfinder. So that really helps with our integration and implementation of Pathfinder. We're going to have a Preparing for Adulthood meeting established in each of the locality teams. And that's where we are going to identify the young people from 14 upwards who we will be coming for a discussion, and we will be preparing their Preparing for Adulthood plan. We'll have our representatives from Children's and Adult Services around the table. And at that point, we'll be able to agree which is the lead practitioner for the Care Act assessment, whether that's an adults worker. And one of the things that will kind of sort of help to define that is probably the complexity of the young person's needs and what might need to be developed for them in adulthood if they need something quite sort of bespoke. And their needs are quite complex, then that's likely to be the adult social worker coming alongside. Okay, next slide, please. But what we're doing within Birth to Settled Adulthood to support our children, social care practitioners, is they have been completing a 16-week induction of learning about adults legislation and practice information. And we are now preparing to develop some bespoke training sessions for team members and enabling them to have mentoring and coaching opportunities. We've developed a Preparing for Adulthood plan that will link to our Child in Need and Child in Care plans. These are sort of in draft form at the moment, but we hope to be able to get those developed on Wellbeing as part of our birth to settled adulthood workflow and set of documents. And we hope that our children's practitioners will hopefully be ready to start sort of their own assessments with support in sort of November, December. And we've been recruiting into our Preparing for Adulthood team, particularly in the area practice manager roles, to support with that training. Okay, next slide. Okay, so in terms of what's gone really well so far and what is really positive, services, I think, really working well and has really embraced the changes positively so far. We've got a clear model for preparing our young adults, our young people for adulthood, and within the localities, how we plan to make that work and drawing our professionals together. We have got a focus on sort of 17 and 16-year-olds because we need to make sure that our model is working well and that we've got the resources in place to do the assessment at the right time. But then we will focus on our 15 and 14-year-olds. And generally, when we're up and running to full speed, it will be from 14 upwards. The work with the NHS is moving forward. We're welcoming Cecilia, and we have got some clear areas of where we think integration and closer working with the NHS will benefit all of our work together. But the challenges have been, there have been some key ones. So I think in terms of the internal resources to support not only Pathfinder, but also the Birth to Settled Adulthood programme has been quite challenging as both, there's been some significant programmes of work that have been happening at the same time. And we're hoping to be able to get our sort of mosaic requirements developed after the 7th of October. And there is a sort of ambitious savings sort of plan attached to the programme as well that spans across children and adults, and we are working through the detail of that. Okay. So I just thought that I would, sorry, if we just move on. Yes, we just wanted to share with you a bit of information about the impact of the service and the outcomes so far, even though it is early days and we're only sort of just 6 months in. Next slide, please. So we're just sharing one of our sort of examples here of an 11-year-old child who's got a diagnosis of learning difficulties and global developmental delay. He is supported within the service within our short breaks team and gets early help support from the service as well. So he's been known to the service since the age of 4, and he attends a specialist school setting. And the family was sort of coming to us identifying that they needed more support, and he's supported by a grandparent as well. The grandparent was no longer able to provide as much support and needed more short breaks support. And it's been really positive. We've had real positive feedback from Jay's parents, who've been provided with a break in care because of they've got complex needs. And also Jay has been building a relationship of trust with a new set of carers and building some independence out in the community. And the family, they, as I say, continue to receive that support, and we are completing regular reviews of that young person. And obviously, as they grow and come into the preparing for adulthood sort of age group, we'll be monitoring that and sort of getting a good understanding of what they need. Next slide, please. So these are just some examples of some of our old where they are at this moment in time. We're sort of planning our new model and working with these young people. So I just wanted to highlight Lisa, which is the first one over here. Is a 16-year-old young person living in residential care since the age of 11. She has complex needs. There was already discussions about planning for her to move on because she felt like she'd outgrown the placement. And in the permanence plans that had been highlighted. So we've started preparing for our adulthood plan for her, and she already has an adult social worker allocated to her who is going to be involved in that joint planning. And really what we want to do is develop the next housing and accommodation and support solution that if she's 16 now and it takes us, sort of a year to 18 months or more to develop it, that it's going to be something that will suit her as she moves into early adulthood and beyond. So yeah, as I say, just lots of examples really of that joint work and the communication, which perhaps, and the oversight of those young people's needs that we didn't have before. Okay, slide please. This is just to give you an overview of what has been developed and is in development with regard to our in-house residential and outreach services within children's services. And again, this particularly supports the opportunity for supporting more parents and carers offering short breaks. So the Hayswood service, which is the sort of light green, that's a new service that opened in April. It's a 3-bedded residential home for children offering short breaks. So they're currently able to offer about 50 nights for young people for short breaks at the moment per month, but that is increasing. And they're also offering an associated outreach service with it, where they'll start to build sort of the relationships with young people and offer support before they move into having a short break with them overnight. So that's really exciting. We've also got in development, sorry, next slide, please. We've got the Rowans in Wimborne, which is a single occupancy, and we're looking to have mental health support there. We've got Sunnyside, which is a single occupancy resource in Weymouth, which supports a young person with complex social and mental health needs. There is the Chalet, which is in Wimborne, which we're currently exploring for short breaks as well, because this setting is sort of really conducive to that. We've got Brackenbury, which is a home that's going to be opened for a young person to move on to their longer term home. We've experienced a few delays with that, but I think we're expecting that to be on course for March 25, because that will allow one of the homes that needs to close and to be closed. And the Dorset Centre of Excellence, which is based in Shaftesbury, that's the north of the county. There's already a school there, but we are talking to them about a proposal for overnight short breaks in that setting as well. So yes, that's the end of the presentation. It was just to give you a flavour of some of the things that are within the whole B2SA programme, and welcome any questions or comments that you might have.
Thoughts, comments, questions?
I was thinking I should have got this screen. So my first question is, how does it connect to the care leavers covenant?
How is it, sorry, connected to?
How does it connect to the care leavers covenant that we've all come in?
Yes, so we have the transitions panel. So within the care leavers service, they have a transitions panel where we've got representatives across children's and adult social care, health, and the various different organisations. So Justine Collum, who is our service manager for Preparing for Adulthood, she attends that, and we obviously link in and make sure that we're directing requests for Care Act assessments to the right teams as well when they come through.
When we talk about having a accommodation strategy, I just need to try and understand how that is aligning with the housing group that's sat underneath the ICP. And I'm not saying that this is not important, but we've got lots and lots of groups across Dorset that don't have settled housing that are all important. So I want to understand how it aligns with that. Is it part of that work? And how we are going through a process of prioritising which elements of that strategy are more important than others.
Yes. So yeah, I mean, lots and lots of need for housing generally. So the housing delivery plan that was agreed by CAB the back end of last year, it set out really our plans, and we're now into the delivery phase of that. So happy to share, the detail of that. But we're very clear about the need for certain types of properties, and underneath that, the types of people that would ideally match to those. So a lot of work's taking place. I think we're looking at all people's needs within that, but massively challenging. But I have to say, I think working at a kind of integrated care partnership level, probably more achievable, pulling all of our resource and expertise into that space.
I think that would be really helpful, because I don't think we've seen that at the ICP. The last conversation we had about housing was, do we think these are the right areas for prioritisation? I don't think we've seen that definitive document from Cabinet.
The joint
round table members have seen them because it was shared with those already.
Yeah, no, but I'm talking about the ICP, because if we haven't seen it.
We've done joint presentations with BCP. This is specific to Dorset Council, but we can clearly pull that out. I'm more than happy to do that in the latest reports as well.
I'm just thinking how we get things joined up so they're not being done in isolation. And then the last thing in my mind was, one of the things that we all struggle with is care package and support packages rising constantly for young people and adults with complex needs like learning disabilities. And much of that applies comes from them not being in the right type of accommodation, which means their needs escalate. And that's not good quality of life for them. This is why I talked about what's our definition of settled. So what within that accommodation plan, what are we doing to address that? That is a quality of life issue for me, that we have got young adults in places that are not suitable for their needs. And as a consequence, they become unwell, and then we medicalise their need, which is not a medical need. Where does that fit into? Where does that fit into this conversation?
You can start if you want.
Yeah, of course. Yeah. I mean, I think that we, within the model, we're able to sort of inform, obviously, better with the information that we gain, of course, planning for a number of types of accommodation. I would say at the moment we've got young people within a transition phase in their life when they do move over. If they have got a high level of support, we're able to, within this group of young people, keep them allocated, and we will continue to review their needs and adjust the support accordingly. So I think that's one of the areas of focus. If they are having more care than really they need, or they need it delivered in a different way, we'll be able to continue to review that. Obviously, we would like to make use of care technology as well, and make sure that the offer is good there, so that if we can find a way of meeting or managing a risk, that doesn't necessarily mean we actually have to provide somebody to assist, and we will do that as well.
That answers the question.
I think isn't one of the key aims of the partnership approach, and working together and working earlier in terms of our assessment and our better planning as a partnership and our early intervention. One of the key impacts we want to have is to stop that escalation of need and rising.
It is, but I suppose there'll always be individuals who's complex work, and you need to make sure they land in the right place in terms of being settled, otherwise their needs escalate. But I think you're right. The bigger issue is how do we get further upstream on those needs? Because what we also know is that if you're neurodiverse or have learning disabilities, if we don't get upstream on those needs, you're more likely to develop complex mental health issues. So there's something about how the whole service model works, isn't there, to get upstream and prevent some of that complexity developing.
That's one of the areas where we have talked about closer integration with the NHS in terms of the children and young people's mental health redesign, the use of funding in the Learning Disability and Autism funding stream to be able to, they're going to invest some money for us to have key workers who will work within the service. So then we can look proactively at managing any kind of crises that may occur, or and we can coordinate that and make sure that we're fully sighted on that, as well as the sort of dynamic support register where we can help to identify those young people that will need support and provide it at the right times.
The only other thing I was going to mention is, I don't know if it was a Freudian slip or intentional, having Cecilia and connecting with the NHS in the same sentence, because Cecilia doesn't work for the NHS. The ICP is not an NHS creation.
Absolutely not.
I didn't want you to get NHS questions, Cecilia.
No, and I absolutely make sure that I'm not seen as a representative of North. Absolutely. No, I mean, if I may come in also, I have spent the last sort of 5-6 weeks talking to individuals, running the service and those involved with the service. And despite what sounds like a lot of mechanistic language and lots of, in discussion with the individuals, you do get to see the real individuals who are at the end of it. So to your point of understanding, I'm certain that is the aim of the service. That is a lot of the work that they're undertaking. They have actually got to meet the parents carers group as well, who were a formidable group who really are making sure that they are being represented. And when they talk about multidisciplinary, I am assured regularly that does include the individual, their parents and are appropriate, that it does bring in education, health, skills, social. And I will say that most of the meetings I've had have been with pairs of people, with a children's sort of service director or even down to the finance team, they turned up as a pair. So I think the coordinated working is being evidenced. I think the challenge to get upstream, I think people are recognising that. I've seen that very strongly, even in just talking to Helen Mason just yesterday, who's doing some of the commissioning. Again, talking about how do I get into planning for the 14-year-olds, not the 16, 17, 18-year-olds. I want to be in there with the 15-year-olds. So I think the challenge is just the scale of it. Is, as you know, waiting lists are big. So we've just got to get into the weeds and say, can we be doing some parallel working where 14-year-olds are evidencing us as being more likely to feel settled earlier? Perhaps we should be working with them. The link to the housing comes through. Obviously, myself as chair being connected to the ICP and the housing table, and we'll make sure that as well as those individuals are working on the housing. There have been several assessments across this place, which show what the need is. The challenge is, as you pointed, the prioritisation of those needs. And there are differences in the needs for those individuals. I think, we will be able to accommodate more the earlier that we know about. I will say, as I say, the fact that it is working multidisciplinary, and it is, although sounding mechanistic, is very much more about the individual and much more needs-led than I had assumed it to be. Much more about the needs of the individual rather than about a diagnosis. And I think that's a significant program as well that we should really work on.
Just to add a practical example of that earlier sort of working that we think will definitely be really helpful is we were doing Care Act assessments sometime post 18. We are, and we'll continue to do Care Act assessments sometime pre-age 18. So, that's helping in terms of identifying identification of needs and proper planning. On the sort of birth to settled adulthood name, we sometimes slip into that 0 to 25 thing. Actually, settled adulthood, that terminology was partly because the carer parent council said, we don't want you just to move the cliff edge a bit further up. Let's not add the cliff edge. So Louise is right. Settled could be 21 or 19 or 22, but it could be 26. Yeah. So, I'm not saying we've got the capacity to work with everyone forever, but it could be in individual cases that, we're still working with someone at 26 because they haven't reached settled adulthood and by agreement.
Autism, 18. You wouldn't know if you spoke to her. We have that conversation this year. What does it mean being an adult? What is it you expect me to do? How am I supposed to be different? And kids don't all grow up at the same pace.
Yeah. And at the other end, we talk a lot, don't we, about
That's true, yeah.
Some come back.
I don't think she's going to be one of them.
We talk a lot, don't we, in this sort of kind of meetings about the older young people, but it is birth to settled adulthood. So we try not to forget that. So we have added extra capacity into the service at different places, and some of the additional capacity is our best start in life advisors. So that 0 to 5 really key age group. We want to do a fantastic job right the way through, not just that bit at the end that does need improving, but so that's really early to make it right all the way through.
Fantastic. I mean, from my perspective, it seems that this is a phenomenally innovative, creative, brilliant programme that started off at concept level and has developed into definite issues that have been able to help individuals. I spent 20 years in the YMCA many years ago, and one of the best feelings you can ever get in your life is when a young person or a young adult comes up to you and you remember them when they were 17, 18, 19 and presenting issues. And they come up to you as an adult, maybe with a girlfriend or a boyfriend or children, and just say, the impact that you had on my life was foundational, was fundamental. And the work that this project is doing, I think, is the same. And it will take years to see the actual outcomes of that. But it's an investment that is I just think is gold into people's lives. I might be prejudiced, but I just think it's absolutely fantastic. So again, if could commend the teams that are doing this. It's lovely to hear the work that's going on. It really does make a meeting that makes you feel good to walk out of, to have some small knowledge of what's going on. Shall we move on to the next item? That large. Oh, we have to formally move the recommendation.
Which is note.
To note the report. Let's do more than note the report. Let's commend the report and look forward to future successes. Which brings us on to the really exciting stuff now. The work programme, to note the work programme that you have there, this draft going forwards, and is probably going to be subject to change as things move and the Newton report becomes more known. And we'll be talking more about that in our next session. There are no urgent items that have cropped up since the start of the meeting or during, and there is no exempt business. So with that, assuming that everybody everybody online is content, that brings us to closing the meeting. Thank you ever so much, everybody, for coming. It's been a joy to spend, even in this weather, in the porter cabin doing geography. It's actually been a really good lesson this afternoon that goes on. Thank you very much. Look forward to the next time. Thank you. If we can now close the meeting, board members who are online, if you want to stay on board, but the live stream itself is going to end.